Thank you for this kind introduction. My name is Kenny van Zwam. I'm, as you know, a perfusionist from the University Hospital in Brussels, and I also work in het Algemeen Stedelijk Ziekenhuis in Aalst. I have no conflict of interest to declare. Extracorporeal CO2 removal already started 40 years ago with Colobau, who described the principle that it was possible when you put a small blood flow through an oxygenator and you give a high gas flow to clear carbon dioxide. In the same year, funnily, Kramer described the first technique of a continuous renal replacement therapy, and it's quite funny to see that nowadays extracorporeal CO2 removers work in the same way, or some arteriovenous ones work in the same way as they would 40 years ago do with renal replacement therapy. Now, why do we need to protect the lung? Is clearly shown in this picture of rat lungs. On the left-hand side, you have a quite healthy lung, and on the right-hand side, you have an abused lung that's being abused for 20 minutes at 45 centimeters of water pressure. So you see, it's clear we need to do something about high pressures during mechanical ventilation. The idea grew from this article to put regional anticoagulation into our system. These guys from the group from Switzenberger, they applied a circulation being anticoagulated with citrate. And so we went to the drawing board. We saw that we could put a catheter into the patient, like we do in normal dialysis. We have this mean green machine, as they call it, on the ICU, who are the nurses very familiar with. And we just put it an oxygenator in between in series. We put some sweep gas on the oxygenator, and we were able to clear with a far less invasive system carbon dioxide. This is how it looks in real life. So it's just interconnected, and we give, with this Sigrist gas blender, we give a gas flow on the oxygenator. Another picture. So how do we anticoagulate our system? This is the protocol from our hospital. We use a mixture of 18 millimoles per liter of citrate, and in the substitution fluids of the dialysis, there's no calcium. Blood goes into the catheter. It's being mixed with the citrate mixture, goes through the dialysis membrane, and is returned to the patient as normal CRRT works. So we adapted a little bit the system. We put a higher blood flow. We had to put more citrate. And the oxygenator is placed behind the dialysis membrane, but in front of the bubble trap. So it's quite a safety feature. And for the nurses also on the ICU, the system will stop if bubbles are detected. The citrate is neutralized by systemically giving calcium chloride to the patient. This group from Maastricht showed that if you use citrate anticoagulation in the same oxygenator as we used, on sheep, on pigs, they added they put the pig on an extracorporeal circulation for about 14 hours, and you clearly see on these microscopic images after the procedure that there were deposits of fibrin on the fibers of the one who was anticoagulated with heparin, but there were no deposits of fibrin on the ones who had been anticoagulated with citrate. Also, in this meta-analysis of 11 randomized controlled trials comparing citrate to heparin, you can see that there's a statistically significant favor for citrate in terms of circuit loss. The same study also saw that there was less tendency to bleed, and there was a higher filter, dialysis membrane filter survival when using citrate. So we did some data collection on the series we did in the University Hospital of Brussels. It's a retrospective case series analysis. We just looked into the database, how our patients were performing when we put them on this system. The data was collected, the blood gas before we started the system, the blood gas after we started the system, and then 4 hours after we started the system. We had a 5-year observation period. We had 34 patients being put on this system, and we could divide them in 2 groups that were patients with just ventilatory failure and patients with multiple organ failure. The average was 3.5 days that they were on the system with a median of 3 days. Now, the data shows us that you get a very fast drop once you start the system, and then it levels out. You can also see that in the statistics. You get a significant drop between T0 and T1, a significant drop if you compare T0 to T2, but there's no significance in between the numbers between after starting the system and 4 hours after it's been started. With the tidal volume, it's a similar story. We could reduce tidal volume significantly, and overall we had a significant reduction in tidal volume. You would also see that here minute volume is being raised, but pressure is lower. All these patients were on pressure-controlled ventilation, and here you see that the tidal volume just got up a little bit, but not significant, but the pressure remained at the same level, and we could also reduce a little bit of the frequency, so the minute volume ventilation dropped. We couldn't see any significant changes in the oxygenation parameters of these patients. Now, the overall survival of 1 month of our patients was only 38.2%, but if we divided them into the 2 groups of ventilatory failure and multiple organ failure, 50% of the patients with ventilatory failure survived, compared to none of our patients with multiple organ failure who survived. The causes for that is because the source of hypercapnia is different in these patients. In the ventilatory failure patients, it's a problem of clearing carbon dioxide. And in the multiple organ failures, as being demonstrated by Professor Ince this morning, it's because of tissue hypoxia. You get an anaerobic metabolism and an overproduction of carbon dioxide in the tissues. You see that especially in septic shock patients. And now, if we look to survival in literature, there were huge differences. Like in this systematic review, there were differences in mortality from 27 to 75%, so you can't conclude anything from that. If you look to the extravent study being done by Bain in 2013, you see that survival got better, but if you compare survival to the control group, and the study group got this tidal volume ventilation of 3 milliliters per kilogram combined with an ECOR system. The control group got a ventilator setting of just 6 milliliters per kilogram on conventional ventilation. There was no difference in in-hospital mortality, but if they did a subgroup analysis in moderate hypoxic patients, they could see that the patients being put on the ECOR device and had far less invasive ventilation had more ventilator-free days. In this study, in this case control study done in patients with COPD exacerbation, we couldn't also show a difference in mortality between the group being on non-invasive ventilation in combination with ECOR or with just conventional normal non-invasive ventilation. What they did see was a significant drop in the days the patient were on the ventilator. So, but there was not. These groups were only quite small, so you can't actually say much about survival in these groups. Now, what this slide quite interests me is what's upcoming in scientific world. Is this last study? It's a study by Ranieri, and this is the pilot trial. They want to perform on a roughly 100 to 120 patients to put them on ECHOR, and they want to perform a randomized controlled trial from this pilot study and they aim to do a large supernova trial, it's called, for about 1,500 patients to see if there's any benefit in survival. So to conclude, low-flow ECHOR on continuous renal replacement therapy is a feasible technique to lower carbon dioxide in hypercapnic ventilatory failure patients. Moreover, it permits lower tidal volume ventilation during mechanical ventilation. We have good responders. Those are the ventilatory failure patients. The non-responders are the multiple organ failure patients, and there's a great necessity for more randomized controlled trials like the supernova trial. So thank you for your attention.